Welcome. Just to make sure you're in the right room, this is competing Medicare reform proposals. Are they really that different? And we're all looking forward to hearing about that. I am Tricia Neuman. I'm at the Kaiser Family Foundation. I direct our program on Medicare policy, and I am your moderator this afternoon, and I'm really happy that you all have stayed. You must be incredible Medicare wonks, since I know many of you were just here at the last session, so it's good to be among fellow wonks. And I also understand that the session comes between the last session and the cocktail hour, so you're not going to want us to go too long into questions, and we'll be sensitive to that. I want to introduce briefly our distinguished panel. First, we have Kavita Patel, who is a fellow in economic studies and the managing director for clinical transformation and delivery at the Engelbert Center for Healthcare Reform at the Brookings Institution. She is a practicing primary care internist at the Johns Hopkins Hospital, and we welcome you. And I also want to welcome Jane Horvath, who's executive director of health policy and reimbursement at Merck, where she's responsible for federal public policy issues such as Medicare Part D, Medicaid, the uninsured, low-income access, health information technology, and health reform implementation. That's quite a lot on your plate. Yeah, she's smiling and looking tired. Okay, so why are we here? We're here to talk about different proposals. But I kind of want to back up for a minute and talk about this concept of Medicare reform, because I think people use the term a lot, and I'm not really clear about what people mean, and I'm wondering if everybody else in the room is really clear about what Medicare reform really means. So if I could have the first slide, please. I can do the first slide. Thank you. Thank you. Okay, we're in Washington. I know a lot of people are here from outside of the Beltway, but in Washington, when people talk about Medicare reform, it really gets down to numbers. It's, we have a problem with the federal budget. We have a federal deficit. We have a debt concern, and because Medicare is 15% of the federal budget and growing, we have a need to do something about Medicare. And so we need to do Medicare reform, because actually what we have is a federal fiscal issue or fiscal crisis, depending on how you feel about the fiscal situation. And indeed, Medicare is 15% of the federal budget and rising. Medicare is a rising share of the economy. The population on Medicare is growing. That presents a problem. Healthcare costs are also rising. That presents a real challenge. So all of this creates a sort of a fiscal scenario that drives people, particularly in Washington, to talk about a Medicare crisis or the need for Medicare reform. And I think it's useful to try to distinguish what's a federal budget crisis versus what is a Medicare reform issue. So I hope we're going to talk a little bit about that today. You know, just to balance out, and I came a little bit late to the last session, so I'm not quite sure how much of this was reviewed before, but while we do have this real federal situation, it is a real federal fiscal problem, there are some countervailing, at least facts, to put out on the table with respect to Medicare. So Medicare, while it's a fairly large share of the budget, Medicare is projected to grow at unprecedentedly slow rates in the near future, which means over the next decade, if, you know, from a CBO kind of budget window, which is a really important thing to remember, particularly when people start thinking, you know, like talking about we need to move rapidly, there's a real crisis. On a per-person basis, Medicare is growing at about the same rate as the economy and growing slower than private insurance. So while there is an issue, there is certainly a long-term issue, both a spending issue and a financing issue. There isn't really a crisis at the moment that looks very different from what we've seen before. In fact, the short-term picture is a little bit rosier than what we've seen before. There's also the reality of many changes that were recently enacted that have yet to take full effect. So we did hear on the last panel, for example, that the Medicare Advantage cuts that were in the ACA have yet to take full effect. And there are a lot of other savings provisions that have yet to take full effect. And there are all the delivery system reforms and the payment system reforms that are just getting launched by the Centers for Medicare and Medicaid Innovations, which have just gotten underway. So there are many things that are just beginning to take place in the Medicare world. It's, it's not exactly sort of a static situation with no change of late. There were actually big changes, and it's kind of a joke around the time of the health reform law where people said it wasn't about Medicare, and suddenly Medicare was the biggest issue, as you recall, at least politically, because of all the savings that were involved. So with our panelists today, I would like to dig a little deeper and talk about why reform. What are we trying to do? What are the goals of Medicare reform? So that we can be really clear when we start to think about solutions, what are the problems that these solutions are intended to address? Is it a fiscal situation? Is it because of the debt and deficit? If so, we kind of know how to drive those solutions, and you have to look for scorable savings, right? That's kind of the way you do it in Washington. Is it to eliminate, is it just to be more efficient? Is it to eliminate excess Medicare spending? Is it to cut back on prices, wasteful services, things people don't need that are sometimes harmful to them? Is that the goal? Is it to leverage lower costs across the board? Use Medicare as an engine to drive change? Should that be the goal? Is it quality? We heard a lot on the last panel about quality. How do you improve quality? How do you involve people in improving quality? How do you involve providers? Is that the goal? Is this, and this is sort of related, but it's more sort of cost focused, is it to really improve care, go where the money is, improve care for high need, high cost populations? This is something, people talk about the small share of the Medicare population that accounts for a large share of spending. Is that the goal of reform? Let's do a better job taking care of really sick people who are expensive. Is it, and this is almost something people don't talk about in Washington right now, is it to improve Medicare in terms of benefits, coverage, financial protections for the low-income population? That was something that came up on the last panel. You don't hear people talk very much about it, even though it is a real issue. And then it's also to finance care for a population that will go from 50 million to 80 million. That, too, is an issue. And these are just a few things that I thought of. I have question marks because I'm sure you're all sitting there going, you know what, she forgot to put on that slide, and I'm going to tell her as soon as I get my first opportunity, which is coming up. So there's some lofty goals here. But when you kind of come to D.C., what happens is people talk about pretty mechanical things that can get scores. And some of the things on this list are mechanical and scoreable, and some are big ideas that could be scoreable or not. But these are the ideas that people are talking about, and we'll get into them. Transferring Medicare into a premium support system, doing that with or without caps, budget constraints that Larry was trying to get into in the last session that we could come back to. Raising premiums, soaking just the rich, or asking everybody to pay more. And by the way, there's a lot of popular support for soaking the rich, but people don't know, or at least the public isn't aware, that much of that was done already in the ACA, so that's sort of the low-hanging fruit has been picked there. I'm not going to go through this whole list, but my point is there are a lot of things that are on the list. And in fact, just to promote for a second, yesterday the Kaiser Family Foundation put out a report with a lot of ideas that could save money for Medicare. We didn't make any recommendations, but we did put these ideas out there because there are a lot of things that people are talking about. If your goal is to achieve savings, is that what we're here to talk about today, or is it to talk about something else? I'm going to turn to our panelists in just a moment, but I did want to point out a few more things. In the context of these discussions, we talk about what's not working, and there's been a lot of discussion about what are the problems with Medicare, and it's not working and all of that. I think it's really important to point out that from the perspective of the beneficiary, our surveys and other surveys shows people like this program. Experts may complain about it. We may talk about all the wrong incentives, but the people who use the program are really grateful for it and think that they like it. So as we are talking about reforms today, I think it's important to remember, you don't want to You don't want to sort of wreck something that's working. You want to fix it and make it better. And also, just because I'm from Kaiser and we always kind of end up with the people kind of thing, just to remember that we're talking about a program that has to work for people with limited incomes, with serious health needs, many of whom have cognitive impairments. So whatever it is we're trying to do to the system, we want to make sure that we do it in a way that will make it continue to work for the people who really need it the most. So on that note, I'm going to turn to two experts on Medicare to get their perspectives on how it is we should be reforming Medicare. But I think before we get to their solutions, I want to back up and ask them, how did I do on the goals of reform? Would you put forward other goals for reform? And where do you suggest the next stage of the policy debate should evolve to?
No, go ahead, you've got it. Jane's got her own proposal. She's ready to fix Medicare. So.
I don't want your proposal.
No, I'm not going to.
Okay.
So.
Not yet.
No, I think you've covered most of it. I do think one of the goals should be increasing accountability and affordability and responsibility in the program, and possibly taking it more local. You know, if you need accountability and responsibility, then taking it more local. It's very hard at a macro level. We may talk about IPAB later, but that should be sort of baked in.
Okay.
So I think you covered everything. I think everything on your list, Tricia, by the way, is everything that, for those of the people in the room that were either in the White House or on the Hill during health reform, these were all the exact same kind of bullet points that we were using for our own playbook, so to speak. So I feel like so many of these conversations, it's not like there are that many new ideas, but it's all about the timing and the other pressures under which we are under. Certainly several years ago, we were under the same, if not worse, economic and fiscal constraints. I think what's different now, your slide is appropriate and all the pieces in there are included. I think what's really a kind of a pressure valve right now is that we're doing all this in the setting of having used up a lot of our pay-fors and a lot of the kind of low-hanging fruit, as well as some of the high-hanging fruit that we're not even sure if it works, but we're hoping and crossing our fingers that they'll deliver. So that, in some ways, to me, heightens some of the anxiety around how do we really tackle these areas. So for those of you who are largely kind of in an academic role and thinking about this from a research perspective, I think it's a tremendous opportunity to understand kind of pre and post, you know, what is it that Medicare was like before, and how are we thinking about whether it's restructuring the program or looking at really particular aspects of it, as I think we'll go into in the next hour.
So let's get to these competing visions. I think it would be helpful, Jane, if you would start to lay out what your thoughts are about what Medicare should look like in the future, how it could evolve, and maybe weave in this idea of local, talked about more local accountability, if that's part of the story.
So I apologize. I know many of you have exactly what I have here, which is this weird throat cough thing. So, but I knew Larry would have a stroke if I called and told him I couldn't come today. So,
I wouldn't have been
because there's no one who's, you know, probably willing to do what I'm going to do here. So, so the reason I got into this, right, is well, I work for Merck. I'm speaking as myself today, but you know, when the super committee started and all the first deficit, the debt ceiling discussion, right? Was that like, how long ago was that now? It was over a year, right? Like like 2 summers ago, right? So yeah. So I am less lofty. I am more pragmatic. It's like, holy Toledo, Batman. They're talking about taking $500 billion out of the program, 500 million to, well, no, 500 billion to $1 trillion out of the program over 10. What would that look like? And so, you know, Merck lets me do lots of different things. So I started to explore what that would look like if they ever got serious, and they've been serious and not so serious and serious and not so serious. So at some point, I think we're really going to be dealing with this issue. So I'm going to keep exploring this. But in the context of the politics and the DC and everything that needs to get accomplished here besides these very lofty programmatic goals, there are things that need to get considered, and which I try to address in the proposal, which is preserving the program that we know, building on what is popular and familiar with beneficiaries, minimizing cost shift to beneficiaries, which is a big deal because some of the stuff that we're talking about on the fee-for-service side is major, major cost shifting to beneficiaries. So you need to understand that there's cost shifting potential everywhere you look in terms of modifying the program or constraining the cost. The proposal obviously has to constrain cost growth over time. I think it has to facilitate innovation in service delivery and treatments, but it can't stymie that. Well, service delivery, financing, and treatment. It has to be flexible for that. I think any proposal has to be agnostic with regard to whether fee-for-service or private sector plans are better than one another. I think you need to let it play out. And probably most importantly, which I haven't heard discussed at all, is it needs to be implemented in the budget window. Okay, so the budget window is a 10-year window that Congress is looking at. There's all sorts of other rules around it. But if you're going to have a proposal to put on the table to say this is something that may be best for beneficiaries, may be best at preserving the system, you better be talking about in the budget window, right? Because otherwise they're going to eviscerate the program and then do what you wanted done, like after the program is not something we recognize anymore. So those are the goals of reform, and then the top line issues that needed to get addressed in any proposal, I believe, are how you treat the low-income population with the special needs and access issues, how you deal with gaming the system if you have private sector participation and risk selection, all of those set of issues, how you create traditional fee-for-service on a level playing field with the private sector, so these are top-line issues because these are the major set of criticisms that you look at if you look at sort of inserting more private sector competition into the program, right? Minimizing the shifting of excess cost to beneficiaries, and I have excess in quotes. CBO scoring, it has to be scorable. Besides being in the budget window, they have to be able to say something about it. It has to be scorable, and potentially with CBO, it has to have a cap. Now, I hate the idea of a cap, but potentially, so that's something we all have to think about too at some point. So I don't know, should I go on, or will you want to deal with those issues?
I think you've given a lot of criteria, but how would you get there?
I think you could possibly, I think you could try to avoid things like combined deductibles, increasing eligibility age, further means testing of the program, which people seem okay with. I'm very bothered by it, but further means testing of the program by trying to construct Medicare Exchange idea. I'm going to stay away from premium support. Okay.
Okay, so let's go into, let's just go into that. The idea of a Medicare Exchange, there are a number of people who definitely don't like to use the word. I understand premium support is now a term people don't like to use.
Yes.
But let's just...
It's poison, right?
Okay, so let's just talk about what we're talking about without giving any terms. So what we're talking about... No,
the program that shall not be named.
Yes. We are talking about a concept where private plans compete against traditional Medicare. Mm-hmm. And the federal government establishes a way... I'm describing Jane's plan. This is kind of silly.
Thank you so much.
The federal government sets a payment. It's all about money, so it has to come up with a way to pay plans in a way that will achieve savings. So there have been a number of proposals. Some have been called defined contribution. Some are called premium support. Then there's the dreaded voucher term. But there are big questions about how payments should be set. Mm-hmm. How should payments be set? Because that's kind of
well, one of the things I think that's potentially very important to think about is regionalizing the operation of the program and having plans compete in a above the county level, which is they make bids right now on a county level in Medicare C, and I just don't think that that's optimal for the future of the program for a whole bunch of reasons. But then the Medicare D program, again, we're talking popular and familiar here, so C and D. The D program is much too large to do bidding on for medical benefits. There's too much variation. So something smaller, larger than a bread box and smaller than a refrigerator, maybe like a metropolitan statistical area, for instance, as a region. And by choosing that kind of size scale, I think you can accomplish several things. One is you can eliminate a good portion of the geographic fight issue that happens in Medicare. Beneficiaries paying for things that happen in New York and they don't know anybody in New York. And if you're trying to constrain costs, New York blowing it through the roof, right? And Ames, Iowa, staying well below, the average cost growth, per capita cost growth. So every region is responsible to themselves. And then also in terms of bidding and everything else, the standard, there's some growing evidence, right, that a lot of the geographic disparity in health spend actually relates to underlying health status, right? And so you sort of incorporate all of that too. And for the fee-for-service would get rolled up and presented as a premium. And then the plans would also bid for the business in that region. And there are a lot of, I'll just say this up front, there's a lot of display issues involved here because this was discussed in the last panel. You can have A, you can have B, you can have ABD, all of these things, and most people have Medigap. And so in terms of displaying these things, we're gonna have to figure out how to bundle up and make Medicare fee-for-service look like this premium over here. The private plan would be offering the combined benefits of A, B, and D.
Why do you have faith that doing something at an MSA level, why is that a better,
Better than
anything? I'm trying to understand. So you're saying, okay, Part C and MA, and I don't want to derail, maybe others are not curious about this, but I'm trying to understand how an MSA type approach, how is that any better? So we then take the geographic variation, and now what we've done is just regionalize it so that New York just gets to blow the budget in New York, and that's limited to New York?
Well, then you get into CBO scoring and caps and things like that.
Right.
But number one, you're starting with the local baseline. You're not trying to pull any region back from where they are. You're sticking your finger in the dike and saying, here's where you are, and then you have to stay on a growth trend of X. So, you could adjust it. Rural areas could get a little X plus something.
And you change the Part D program to also be regional?
The fee-for-service side, except for, the display and how a beneficiary would choose it, stays the same.
I bet you we could come back to a lot of questions about this, and I think rather than maybe what we'll do is come back and have you all ask some questions about this, because I think there are big questions about how do you deal with regional variations. There are questions about payments, and these are complicated issues, and you may or may not be as interested in the weeds of this as some of us weedier ones, but we could certainly come back to that. Are there other elements? You talked about low-income protections.
Yeah, I think that's another really important part. We would, this proposal, the idea would be to take the subsidies schema that exists between Medicare and Medicaid, right? So it's basically up to 150% of poverty, but use the Part D precedent, which is Medicaid is not involved in subsidizing the low-income people in Part D. It's 100% Medicare. And so basically it would be federalizing the duals for the Medicare portion of their services in Medicare, basically.
One of the things that's interesting is that in the with the ACA, there's a different standard for low-income protections than there currently is under Medicare. And I'm looking at Joe because he's done some work in this area at the Medicare Rights Center. But there is a difference in terms of who will be eligible for low-income assistance once the ACA is implemented, and who will be eligible for low-income assistance under current law, under Medicare. People are, there's not a lot of discussion even today about raising federalizing low-income assistance under Medicare, much less raising it to the Part D standard, much less equalizing it to what it would be if it were equivalent to the health reform law. Is that something that you think is a good idea? Do you have concerns about the costs of that relative to the savings that you're hoping to achieve on the other side?
I think the more low-income protection you can provide, the better, the better the program is. I think it's a budget issue. And just for purposes of this, trying to build on precedent, what we know today, again, the familiar. So this is sort of the level of subsidy, and this is how it works in Part D and Medicaid. So it sort of chose the best of both, other than budget issues. And the interesting thing, I think that, over time, buying out the Medicaid portion for the Medicare costs actually has the potential to save the federal government some money. It's an investment originally, in the first few years, but depending on how CBO would think about moving people into, the duals would move over into managed care, into a plan, basically.
Would that be a requirement under your proposal?
Yeah, they have the option to move over into this Medicare Exchange, and if they do, they would move into a private plan, but they are not required to. So anyway, but there are savings involved in that movement, I think, in terms of how CBO would think about it relative to Medicaid sort of fee-for-service. And the other piece I will say that I think is an important component to how this all works and relates to the duals demonstrations today is the low-income population would be fully subsidized in one of these Medicare Exchange plans if they were enrolled in a plan that's below benchmark, at or below the enrollment weighted average benchmark, which is totally pulled from Part D. That's how the low-income subsidized population is addressed in Part D. They're fully subsidized up to whatever is provided in the law when they enroll in one of these at benchmark or below plans. And there's quite a choice of plans in every region that are at or below benchmark for a couple reasons. One is it's an enrollment weighted average benchmark, so it reflects consumer choice. And the other thing, just as a business piece, the duals line of business or book of business of the dually eligible population is actually very attractive to plans. Because
Can you explain that to us?
Yeah, I have surmised this. I mean, I've just surmised this from watching Part D and then watching sort of all the plan excitement around the duals demos. Because it's real, and plans do tend to try to bid at or below benchmark, try to figure out where that point is so that they can get some duals enrollment. Because there's a lot of care management that can be applied relative to the capitation that they get paid. Low-hanging fruit, if you will. And so anyway, it's a very attractive population, the capitation versus what they can produce in terms of management savings. So it's very important, I think, in terms of overall cost containment to keep the duals population in the structure and have the bidding be like it is in Part D. I think that's part of the reason why Part D premiums stay low year after year. The national average premium, I know there's regional variation, but the national average premium is always getting pulled down a little bit. And I think it's because plans are aiming to get those dual lives, and they have to hit it right.
And would there be, what about duals who stay in traditional Medicare? Do they get what they get? Do they get?
Yeah, it's just like today, and Medicaid wraps around and all of that.
Okay. Kavita, let me get you in the discussion.
Sure. I don't have my own proposal, so I'm not sure if what I might do is actually describe some of the work that's going on at Brookings. I might describe, in the spirit of the title of this talk, kind of competing proposals, kind of what's happening around town, but maybe highlight what's getting more traction on the Hill and what seems to be some of the points of tension, at least, and using your framework, I think, of kind of where this is. And I think that we're in a time of constrained resources. Nobody likes to talk about how that has effects, But by and large, what everybody has been doing around town, including some of our work at Brookings, has been thinking, let's first set what our budget target should be. And I think, Tricia, you mentioned this, that growth has been modest in Medicare. There's been some debate as to whether that's the recession and the effects of the recession, and that we're still seeing some of that, or whether there's some interaction effects of the recession, as well as some of these delivery reforms. I mean, I'm not going to pretend to personally know, but I will say it's complicated to sort out why it's been modest. Having said that, many, including what we're doing at Brookings, other people in town, Bipartisan Policy Center, Center for American Progress, certainly Bob he spoke to some of this, Bob Rushauer, in the last panel. Almost every shop in town has been working and thinking through options, and they're generally starting with kind of a GDP target, since that's at least in throwbacks to fiscal constraints as well as what CBO can understand and what we can score, and then they're kind of going backwards. So GDP plus 1 seems like a very attractive budget target, economic target to set, and then given that Medicare's growth has been 1.2 to about 2%, and then that's been considered modest, you can understand GDP plus 1 still raising eyebrows in terms of how do we get there. And by and large, once you start kind of deconstructing how to get there, we're really looking at thinking whether it's premium support or however you label it, changing the age of eligibility and the constructs around what that would entail. And that's certainly where there's been a lot of kind of ideological divide to change the eligibility age and what savings that can garner. But then when you go a layer deeper, and what we're doing at Brookings, for example, is looking at the various incentives. So Part B has been my personal focus, just because if we talk about realigning incentives and moving some chunk of money away from fee-for-service based reimbursement, is that going to make kind of a downstream difference, and how much savings will that generate? So there's taking each of the programs, and I would say in terms of competing proposals, there's the philosophy of let's take all providers and put them all into ACOs on steroids. So the accountable care, and I think Gail kind of touched on this in the last panel, that a number of things that were done in the ACA allowed for the legal movement into accountable care payment arrangements. And in some ways, just listening to what Jane was proposing, you could argue that a mini version that's been taken up in many regards is that people are regionalizing care at the provider level. So it's not necessarily at the full benefit level, but certainly in the provision of services, and that's largely limited, since it's Part B, to kind of outpatient services. And then you're also seeing kind of in terms of competing ideas, so then there's how do you get there and how do you do that. The other competing sets of ideas are around low-income populations, and I'll just say it's the duals, and it's swaps. I mean, John Holohan's written very eloquently about the ills and the pros and the cons, and Judy Fader and others around kind of what we would do if we federalized aspects of the duals and the care around that. That's a big coster. It may save in the long run, but at least in our kind of early conversations and analyses, it's something that the federal government would have to take on in such a different light, that if you think about the debate around class and what we couldn't do in terms of long-term care, it's hard for me to see a very proximal pathway to doing this with the duals. So the competing proposals and where we've tried to encourage movement in the areas of the duals has been to allow what the Office of the Coordination of the Dual Eligibles is trying to do with some of these demonstrations, and there's obviously been some political tension around that. The third piece of it has to do with kind of how you break down. So once we get into kind of Part A savings, Part B savings, and thinking about, and I think, Tricia, I will say that your policy options book was reminiscent to me of the CBO options book that came out 4 years ago, where everybody was earmarking it and thinking, okay, how much can I save if we do this? And so that's exactly the same level of discourse in all the proposals around town, where I've seen there be a great deal of agreement, and so I'll start with that, has been around setting these overlaying budget targets, GDP plus 1, and kind of working backwards. Where I've seen utter disagreement has been on the kind of alignment of the structure. So how do you take A, B, C, and D and think about changing the actual benefit packages, and how much of that is a footprint of the federal government versus how much can we get away with by putting in a better CAP program, a competitive acquisition program, better competitive bidding. And I think there's Whereas 4 years ago, 5 years ago, some of you may remember, when we were talking about competitive acquisition programs, and there was some demonstrations longer than 5 years ago, demonstrations around that effect, we said it failed. Everybody's taking those books off the shelf and trying to dust them off to see if there's some possibilities there. And in every shop around town that's looking at some of these competing proposals, I will tell you that the biggest hiccup we're finding is doing something in like the 10-year window and getting kind of the beautiful CBO scorable type of estimates. And you see the numbers of savings that you can generate from something like a premium support, a voucher program, or a defined contribution program, and that's just hanging out there. So I will kind of tell you that my final thought has been around once you think about what the right proposal is or pieces of the proposal. Oh, and by the way, there has been, I've been reading about kind of this in-between MA and traditional fee-for-service Medicare proposal that has been out there that's been, I think, supported by the insurance. I could be wrong, but I think there have been aspects that the insurance industry have supported. And what I think it's telling us is that people are looking for something not quite MA, not quite traditional Medicare, but in between. So whether that's, Jane, what you described, or Part E, I have no idea, but I do know that that's another proposal that's out there. And we can go into maybe the pros and cons. I think what we've been trying to do, at least at our work at Brookings, has been to we've adopted the philosophy also of take what's working, but we're taking a little bit of a gamble on what's working and hoping that those decreased and slowed down Medicare growth rates will continue despite some of the projections that we've done in the out years, especially after 2018, where there's a projected uptick in Medicare per capita gross spending. And then we're going to be facing now what do we do? So I didn't go into like my own proposal, but I'm giving you pieces of things, and I don't know if we want to go into some of that.
Jane, I think you want to say something.
So I just want to say that, I think I have a lot of optimism about all of the pieces, the innovation pieces in Medicare, in the ACA that the CMMI is executing on. And I think those are going to sort of, those are just sort of rolled up in this, Some of those ACOs over time may be actually willing and able and licensed to take risk, and be a regional plan even. So all of that movement, experimentation, and to the extent that it is reducing costs and stuff gets rolled in. And then I just wanted to argue against a cap, even though I think it's probably going to be necessary at some point, just given where CBO is. I think if you're going to spend more money if you have a cap than if you didn't have a cap. Because you know where the ceiling is, and it's a little complicated, but I'm sure it's not rocket science for a plan to figure out sort of the competition. A 5-year rolling average of GDP +1 is not major math, right? And then figuring out where your premium is, what your competition might do, and and you won't blow through your cap. Once you put a cap in, people go there.
That would imply that it would be enforced at the plan level, as opposed to at an aggregate level that is a little bit harder to predict and
no, at the regional level. Again, because that's the other thing is,
so if you were to GDP.
A national GDP applied regionally.
Okay.
So I think when you apply a GDP regionally, your cap can be larger because it's not applied nationally. So you're catching sort of growth in certain areas and sort of tamping things down, whereas the national estimates of Medicare growth are well below GDP +1, right now. So it would save nothing. If you apply it regionally, I think you would still get savings because it's not random, and there's a way to, you smooth the GDP, you give people credit for good behavior in years past. But so I think I don't want to have a cap, but if you had a cap, I think you would need to have it regionally so that it could be, a larger cap, a higher cap.
All right. I know we have a lot of smart people in this room, so I'm going to ask one question, but I'm hoping that you all will come to the microphone and get involved in this. And if not, I could ask a million questions because I have a million questions. But while you're getting ready and getting an afternoon stretch because it's at 2 in the afternoon, I guess here's my question. My question is one about timing, because Jane, what you're talking about is a pretty fundamental change in Medicare in terms of budgeting and organization. It keeps a lot, it builds on a lot, but it's a big change in terms of budgeting local, regional areas and having traditional Medicare compete on the same, on a level payment, level field with private insurance. That's a big change, and it could bring great things. It also could bring risks, as any kind of big change can do. At the same time, there are kind of all these changes that are being tested that may or may not work, right? There's all the stuff that CMMI is doing that's being baked into the system that could do well, could fail, who knows? What's the right timing? Do we sort of wait and see? Do we see how the program evolves? Do we test all the innovations? Do we say, hey, Medicare's actually growing much slower than a lot slower than GDP plus 1 or 2 right now? Let's have a plan that says, let's come back and revisit this 5 years from now if spending spikes, and then we have to do something pretty substantial. Or do we say, no, CMMI is not moving fast enough, we don't trust these projections, because a lot of people here have noted that, you know, spending rises and falls, so we ought to act right now.
Well, I'm all in on waiting. I mean, you know, this is not like a proposal I think that you would have to do, as Gail was saying before. You know, there's the exigency of having to do something has sort of slipped away right now. This is, you know, this is your break glass, right? If you have to take $1 billion out of the program over 10, and I would say it's structured in such a way that you could actually start it in the budget window. That was like a key thing here, because everybody can continue to choose their fee-for-service.
That was really political, right? I mean, that starting it outside the budget window was a political consideration.
Right, but most of the stuff that's been out there has been, like Ryan and Ryan Wyden, have been pretty draconian. I would argue that this is, I know everybody probably disagrees with me, but I don't think that this is all that draconian. I think that this incorporates a lot of what is. You know, it incorporates ACA, right, sort of the exchange mentality, and people are going to have to be picking their plans. And I think the ACA, when you look at what's going to be happening inside the exchange in particular, but inside and outside in the small group market, things are going to be tightening up. You know, benefits are, you know, my personal hope with the ACA was that benefits would ultimately be more robust. And in certain ways they are, like access to preventive services and things, but at another level, you know, the plans, I'm quite certain, are anticipating real tight, tough times. And then when you look at how actuarially the metal levels play out, people are going to be used to having to make really smart decisions. And when I look at changing Medicare, making it sustainable for the future, I'm also thinking about 20 and 30 years from now, assuming ACA has been implemented, that it's successful. You know, that, again, it's another thing with which people become familiar.
Okay. Kavita, do you want to say anything, or we'll go to the mics?
I just know that not only what we're working on, but a number of different areas, that the thought is that it's going to be something that we have to deal with in at least this Congress, and if not that, then the next. And it's being pressured because every year we're still doing these shaves and our own draconian set of cuts in order to offset things like the reduction in physician payment rates and what we just went through with the fiscal cliff. So we're creepily doing kind of draconian measures to cut Medicare spending, and it may not happen in this spring while we're dealing with the debt ceiling, but I will tell you that there is certainly a great appetite to do something in the program in the next couple of years. Whether we have the political will to do it, that's, you know, a bigger panel than me, but it's certainly something I think we'll have to, though there are already so many proposals on the table, it's going to compel a reaction to say, all right, let's try to do some aspect of this.
Okay, so let's go to the mics. Let's start right there, because I think you've been standing the longest. Can you introduce yourself and say where you're from?
Sure. I'm Kristin Franco, so I'm from the Peterson Foundation. I think we've talked here, and a lot of people here already know that there's a lot of really good ideas on the table, and the system is kind of in the process of changing, especially payment reform, you know, in the coming years. So I guess my question is, where is the opportunity for both policymakers and people working in think tanks and advocacy organizations? Where is the role for change to make those happen and to kind of accelerate things?
I'll speak from a payment perspective. One of the largest struggles we have is actually describing the transition. So one thing I'll tell you, and I used to be someone who would just soundly say we must move away from fee-for-service. I say that now with an asterisk. We don't necessarily want to move everything away from fee-for-service. There are certain aspects we need to retain, preventive services, some kind of very highly specialized procedures that we don't want to kind of incentivize in a different way. But what's the biggest struggle from a policy-making perspective as well as a thought perspective is how do we look at a transition model in payment, for example, from traditional fee-for-service as being the dominant payment system to something else. I mean, even with this buzz about ACOs, we only have over several million beneficiaries in these ACOs, and we're not even sure exactly if this will work. So how, and that's still done on a fee-for-service basis, just to remind you. So I think the biggest challenge, at least from a payment perspective in my mind, is this transition. And then what's the time period of the transition? What does this look like? What do the incentives need to be on the other end to get providers to be incentivized to move away from what they currently have? And then how do you decrease the offering of choice between staying in a fee-for-service payment system to something else? And I think nobody has dug out and figured out the secret sauce on that.
Oh, sorry, I'm alternating.
Okay, Joe White, Case Western Reserve. First of all, there's a factual question, which is if people can comment on the reasons for the current slow growth per capita. I would expect slow growth per capita to be a combination of demographics. We're having healthier people moving into the system because of the baby boom group coming in large numbers beginning around now, and also the recession, with people, to the extent they have to pay out of pocket, not being able to, and therefore not consuming services. But if people have ideas about what has happened, that would be useful. It seems to me that there's three big disagreements that aren't really being talked about here, at least two big disagreements and one big possibility. The first big disagreement is whether we should be talking about reforming Medicare or reforming the whole system. And in particular, if you're going to focus on costs, if it makes any, we always say, hey, it's a healthcare system problem, so why are we talking about Medicare in particular? And to say, well, we can pilot in Medicare is sort of begging the question. Well, maybe we can't. Secondly, there's a real hidden disagreement here between the people who think that what we need to do is get away from fee-for-service, which may be the majority of the people who are speaking today, and the people who think the problem is our fees for service, as Bob Reischauer mentioned earlier. And you can have reform of the prices, and in particular of the relative values for hospital services and for physician services without fixing without getting rid of fee-for-service. And I think in general, the people who talk about foreign examples are saying, hey, right, a lot of those systems are fee-for-service, but they got the prices much closer to being right. And there are a lot of people in the American arena, like Bob Berenson and Paul Ginsberg, who are making the same argument, and that's not really coming up here. It's in stuff, sort of, but the get the prices right agenda, there could be a lot of money there. It fixes the SGR, and so I'd like to hear some comments on that. And then the other thing is fraud. Yeah, fraud. You know, it turns out that maybe some of South Florida is that you have a whole lot of people who weren't insured before, so they go on Medicare, and so they're high volume because they're actually sicker, really, and Dartmouth never picked that up. But a lot of what's happening in South Florida or in McAllen and so on is fraud. And back in 1996, 1997, we saved a lot of money by cutting fraud. And so where does that come in?
Let me start in reverse. The fraud issue, I couldn't agree more, and we actually, there are many provisions within the Affordable Care Act, and the administration, you know, I'm not here to defend the administration, but I will tell you that they've been doing more than I've seen, at least in the last several administrations, to try to put that front and center I agree, though, it's probably only scratching the surface. So in terms of these competing proposals around town, I would say that that's actually kind of across the bar a line of agreement is what I would lump together as fraud. And then in that same conversation is transparency as well, transparency and accountability of cost, and some kind of holding plans who are in the Medicare space to actually demonstrate that what they've spent on these beneficiaries is accountable for services, et cetera. So, and then stepping back, I agree with the fees for service comment. I'll give you one example of how we're trying to deal with that, and what we're proposing is looking at the perversity of being paid $192 for an echocardiogram in an ambulatory office-based setting versus being reimbursed for that exact same procedure by the exact same doctor, $600 in a hospital-based facility. So site of location, who cares whether you're in a fee for, doesn't matter if you're in fee for service, that is wrong. And that's one example. So you're correct, and I think that the conversation that always circles around move away from fee-for-service is largely a nod not just to what you alluded to, which is RVUs and the RBRVS system, which is relatively broken now that technologies are deemed to be such high intensity and cognitive services are not necessarily regarded as such. I think the concept, though, around moving away from fee-for-service is that it's not just I think it's really around also kind of how does this fit into how we change the delivery system, and that's why there is such a traction in that. I mean, so I'm not defending one, I'm just saying that you kind of have to do both. You can't really, you can't tease them apart. You have to fix what's wrong in fee-for-service and some of those valuation issues, but we must constantly be pushing to change and kind of move that needle away from just thinking of this as a cottage industry where we can do what we want. And then reforming Medicare or the health system, I think there are a number of us who go through these battles all the time. I tend to be narrow in at least what can I work in where I have some ability to have traction, and I know that even though the private sector leads in a lot of areas, they also wait and watch to see what Medicare does for many decisions. So from a practical standpoint, I think what we have to do starts in Medicare, but the idea and the concept is that it flourishes, and I think some previous speakers have alluded to that. And then there is still a debate about the slowing in growth, and when we've looked at demographics and the baby boomers who are generally healthier, that's not necessarily enough of a predictor, or it doesn't attribute enough for the slowing in the growth. And so I think this will be a debate amongst economists to come as to which is the driving factor, the recession or truly some of these reforms. So that's my bullet shot answers.
I thought for sure you'd say we already did reform.
Well, we did reform, but we don't know if it actually worked. So,
so I'm not ready to start again.
I mean, I just have to say one thing about fraud, which is it would be really nice to make everything go away if we could get rid of fraud. We have a whole section in here on program integrity because people desperately want to say, let's take care of fraud, let's take care of the problem, and then it would be painless. It would be marvelous. But when you talk to every expert, which we did, believe me, you cannot get a lot of money that is scorable that's called program integrity or anti-fraud. There's just, you might believe it, you might be right, but it is hard to come up with a proposal that will really do the job and make a big dent in the kind of things that we're talking about.
I'd just like to add on that, though, that while it's very hard to make it scorable, and it wasn't predicted, it wasn't predicted in 96, 97. It's very hard to make it scorable. But I just remember 99 or something, one of these meetings, and Marilyn Moon was talking about this, and she said, like everybody else in the health policy world, I always figured you couldn't get much money out of fraud, and it turns out that if you take a bunch of healthcare executives and put them in orange suits in a federal prison, other healthcare executives notice and change their behavior. So you're right, it's very hard to score, and I'm not sure how much is there, but it is something that is worth considering.
Right, I agree. And the Justice Department has been pretty aggressive of late. Yeah. But I'm just saying we can't sort of say, okay, we're done, let's go for fraud.
Check that box. Yeah.
I know.
It's the left-right confusion.
I know. I'm always having the left-right confusion.
I'm Joanne Lynn from Altarum Institute Center for Elder Care and Advanced Illness. I just wanted to put on the table some probably ideas a little bit beyond the edge of what we count as the mainstream proposals, but they're becoming much more appealing. And I think we're going to either have, as a fact, or be able to create some real crises in the next few years. And good crisis is unfortunate to waste. And it seems that, one or another thing is going to really focus attention on the costs and the crumminess of our system, just how bad it is. So maybe if we were ready, some more radical proposals could at least have their day as a trial. When the last gentleman was talking about expanding our scope, I was saying, oh yes, he's going to go the right direction. Then no, he went to more medicine. Most of Medicare costs are in the care of us when we get very old and frail. Half of our lifetime expenses are living with the illnesses that eventually kill us. Half of us in the room will have frailty and a quarter will have dementia. These are really big numbers, but it's in long-term care, it's in housing, it's in caregivers, it's in caregiver support, it's in direct care workers. Runs up huge amounts of money, and it's the biggest expense that people are not generally insured against. Medicare doesn't actually touch it. What we do, however, is pull all kinds of expenses under the Medicare, or if necessary, the Medicaid umbrella, because we don't cover them in any other way. And we have these suffering people in front of us, and what are we supposed to do? So when the improvement standard died last week, I can run up a bill in Washington, D.C. of double any home care patient that's out there now that the improvement standard is gone. You want me to do that? We can precipitate a crisis. Because we aren't thinking about how to serve this population. We built Medicare on the hopes and fears of 50-year-old men in suits who are scared of heart attacks. And by damn, it is good for heart attacks. But it is not good for 88-year-old ladies in second-floor walk-ups who can't figure out how to get the groceries in. So if we step back and said, here's a whole phase of life, which almost all of us were denied in 1960. Very few of us got to have that piece of life. And if you did, everybody around you assumed that you didn't use much medical care. You might do some other things, but not much medical care, because you were old and you were senile or whatever it was we labeled you at the time. But now most of us will get that time. It'll be 2 or 3 years long. It'll run up huge bills. Why don't we start thinking about combining the social services and supports, the environmental services, the long-term services and supports, and the Medicare funding in one coherent package? Require continuity, demand good care plans, demand feedback loops that educate people as to what really works, but operate it perhaps more like schools, where it's a community endeavor and it's run as a community endeavor for that population. And try to work it on a budget. It would be some kind of a budgeted or capitated sort of thing. It certainly wouldn't be fee-for-service. That'd be like doing fee-for-service for the public schools, Here's your cost for trigonometry or something. But if you think about it coherently that way, and then look at the gains being made in care transitions, how easy it was for us to wipe out 6% of the hospitalization costs, and the social capital that's growing as ACOs and care transitions and other things start making communities start talking to one another. Maybe there's a nexus there for a very different kind of delivery system for that really expensive piece of life. And if we were ready to push it in the next time that there was a good crisis that made people's minds open to it, maybe we could get beyond how to refinance a care system that is just fundamentally the wrong fit. Or maybe there's some other good ideas like that we could start working with rather than just how to get enough money to keep our current malaise going. What do you think?
I think that you've given an answer.
Yes. You proposed.
Do you all want to comment? That's a great. Do you want to comment?
No, it's a great.
That was a great.
Joanne, that's a great. You talk about time for
do it.
radical solutions. It's a great time. That's not a there is no better time. People said the same about doing health reform. In a time of a recession, and look what they're talking about immigration reform when we didn't think people would actually agree on that. I think you're right. It's just a matter of, I'm sitting there as you're talking going, well, that's municipal, that's county, that's state, and that's federal. How do we actually, we can barely do the federal and state
That's
really
area
well.
agencies
So
on aging
I'm just
and
thinking,
housing, yeah.
I can barely get CMS to talk to the FDA. How do I get like these people to talk to each other? But that's,
But why don't we
that's,
mandate that
those are-
CMMI finds 6 communities that are willing to start offering this to willing beneficiaries? I mean, you'd have to have an opt-out, and make it so attractive that everybody else wants it.
Okay,
it's so
thank you. Let
easy.
me go to the next mic.
This is Gary Franklin from Washington State. I oversee workers' comp health care in Washington, and one thing about Washington is our governor and our legislature expects us all to work together. I mean, I don't know of another state where workers' comp and Medicaid and the corrections and the Department of Health and state employees all sit in the same room to try to figure out solutions together. So one issue here is, how can we get all of these groups to work more together so we can have similar policies? But my 2 very specific things are, we know a lot, and, whatever happened to that whole waste argument, I don't know if it's 1/3 or 38% or 27%, but whatever it is, it's a lot. And some of it's inefficiency, and some of it is just stuff that doesn't work, or that harms people, or that, God forbid, isn't worth the money. But to me, it isn't really rationing. It's only rationing if you don't let somebody have something that they actually need and that will work. It is not rationing if you don't want to pay for an MRI in the first 6 weeks after a back injury, because 99% of people agree you shouldn't do that unless there's a red flag. So I don't understand why we're not having a more serious discussion about this waste in that area. Another example is physician dispensing, of repackaged drugs. I mean, everybody knows about all this stuff. It's, 4 times more expensive than the drugs in the pharmacy. So, and the second point I want to make is, we know a lot already about the 5% taking 85% of the dollars. We should really, on steroids, try to get at improving care coordination for these patients in communities, in ERs, in hospitals, to prevent these frequent flyers in the EDs and the rehospitalizations, these people that are churning. So 2 very specific things. The second one is kind of something you need incentives for, and the first one is, why aren't we more serious about the waste?
Do you want to take this?
Well, I mean, your waste may be my medically appropriate service. I mean, number one, I don't mean to be glib about it, but that is part of the problem here. And so, for instance, we had John's still in the room. John, what's the name of the organization, right, that put out the recommendations, started to identify services that...
ABIM.
Choosing wisely.
Yes,
Right.
right. So, we're moving in that direction, but that's, and actually I did not get a bone density scan as a result of that. My doctor recommended it, I said no. But we're moving in that direction, but it's, provider education in part. I mean, the doctors recommend it, and you have to buck against it.
So I'll just say something about waste, because I couldn't agree with you more. And I would argue, I get to spend a lot of time being at a think tank. People let you kind of sit in the room when conversations are happening. I don't think they realize I'm in the room. So I sit in the room with high-level executives and payer communities, and they're trying to get at the waste issue by narrowly tiering the benefits in such a way where it is so difficult. I mean, so I can't order an MRI because I go through a radiology benefit manager. As soon as I order that MRI, what triggers is instantly a phone call from a nurse who's reviewed that back to me. And so I would argue that it's certainly not getting at the waste. The IOM recently released a report that kind of outlined, hundreds of billions of dollars of opportunity still for inefficiency and waste. I would say to you that what we have to do is have a more honest dialogue about it, because whether we're talking about the Medicare program, or as I mentioned, my example was in the commercial payer setting, so not even in the Medicare setting, I think that what we're discussing, though, is a very clear sense of, if there's evidence to support it, we're just not going to pay for it. Medicare has certainly started that with the never pay events, and they've expanded what those events are. It will not surprise me in the very least to see some of the things that have been adopted by professional societies that we should not be doing, like EKGs as part of an annual well visit, that those things were adopted as things that are not paid for by payers such as Medicare. So, and then just on that rehospitalization and kind of the 5%, just to piggyback on what Joanne suggested, I think that's exactly where some of these innovations are trying to go. I've been keeping track, I think Tricia has, a lot of us have been kind of keeping track of programs that are working and trying to get to that 5%. And they're doing so by getting the community together and kind of going in at risk for the care of these patients and saying, we know we can do better, give us a little bit of the infrastructure and capital resources we need to get these programs up and running, and we will actually find a way to do it. Jeff Brenner's doing it in New Jersey, Rashika Fernanderpool's doing this and actually making money off of it in other clinics around the country. So there are models that are out there. Are we getting to that 5%? Clearly not. But I feel optimistic that we're starting to do the right direction.
I just wanted to add one more point to this in terms of culture. Do you remember, right, when the health reform bill was on the floor, I think, in the Senate, and the U.S. Preventive Services Task Force came out with
a very timely recommendation around mammograms.
Yeah,
yes, of course I remember
do
that.
less of
Yes.
them,
Right.
and the political
Between the ages of 40 and 45.
Yeah, yes, but just, and that was just politically unacceptable. All hell broke loose, basically. And then I think Mikulski came around, right, with her amendment to to have the IOM figure out what should be first dollar coverage for women's preventive services. So, and then the U.S. Preventive Services Task Force, which is now actually given a bunch of power. I'm not sure they wanted it, but they're given a bunch of power, whatever they rate as A or B in terms of efficacy and effectiveness, Medicare will automatically cover now. And similarly, what they do not rate as A and B, the Secretary can remove as a covered service. Right. I'm not sure she ever will.
But one of the things that the Secretary is prohibited from doing is taking cost into consideration.
That's true.
Right? And so that's a whole interesting area that we haven't gotten into as to whether or not that's a reasonable thing to do or not. It's a very controversial idea, but it is something that some people have put on the table. When you have things that are equivalent and one is a lot more expensive, should Medicare pay for both or either? And we could have a long conversation about that. Lee?
Yeah, Lee Goldberg with NASI. So I had a question, Jane, for you for your proposal. Would it be something that is built on Part C or not? And if not, why not? Because it seems like Part C is a great platform to see what the role of private plans is in Medicare. And until we sort of figure that out and get it right, why mess with something that may be imperfect but at least guarantees access in A and B?
I'm not operating at that level with this couple pages of paper. We just thought Part E and Medicare Exchange might be kind of interesting, but whether it replaces Part C or Part C morphs into this, but ultimately there would be no need for the two programs.
Hi, I'm Kim Rutledge, and I am with AFSCME in California. I work for a labor union that represents 65,000 home caregivers that are under our Medicaid program. And I am really closely involved in the duals demonstration in California right now. That's kind of the model for the country. And I have two questions related to duals of things you guys mentioned earlier. My first question is specifically for Jane. When you made the comment that duals are attractive to the MCOs, in California we're kind of being told the opposite because they're already starting to cover some of what in California we call the SPDs, which are the seniors and people with disabilities that are Medicaid only. And our local area MCOs are saying that this population is causing them to lose a lot of money, and they're really nervous about taking on the duals in the next few months. So I was hoping you could expand on that. And then I have one other, I'll just get my other question out there. My other question is, could somebody give like a brief but slightly in the weeds explanation of what federalizing the duals would look like, since the very definition of being a dual is Medicare and Medicaid, and Medicaid is a state program. So I'm just curious about that.
Okay, so why don't we start, Jane, with the first question?
Sure. So I think maybe what's going on is the plans you're talking about are Medicaid managed care plans, right? Yeah. So that's different. I mean, their experience is different than they're getting Medicaid rates for state-only, or Medicaid-only population, I guess, right? Because in Medicaid, you actually can't enroll people with disabilities into a Medicaid managed care plan on a mandatory basis without a waiver. So I think that's a separate issue. And I think what California is talking about is, I do not believe that they're talking about enrolling like the SSI-related population, are they?
Sorry. Yeah, they would be eventually
Oh,
enrolling.
I'm sorry, that was a really stupid statement, yes. I mean, but what we're talking about is the Medicare managed care plans.
But doesn't this have a lot to do with a couple of factors? One is, the biggest one is, what's the payment to the plan? So plans are going to do just fine if the payment's relatively generous.
Yes.
So in areas where Medicare payments are generous, say relative to fee-for-service costs, why, it seems like there's a good shot of that, right? But in other areas where payments are not as, for example, in LA, right, where payments are at 95% or below fee-for-service costs, then maybe there could be other issues, maybe it's more difficult. And so the effects would really vary depending on how much Medicare contributes to the pot, how much Medicaid contributes to the pot, how much savings are taken off the top, because this is about achieving savings as well. Right. And all of those factors sort of play into the question of whether plans can make money. And as we all know, this is a sicker, more expensive population than the average Medicare population. Second question was kind of a straightforward one about federalizing duals.
So, there's probably many definitions in terms of what I was thinking about related to the demos would be federalizing the Medicare portion of their services, not have Medicaid wrap around.
So do you mean premiums and cost sharing, premiums, cost sharing, and Medicaid benefits?
Premiums and cost sharing. And then the long-term services and supports would be basically you could do what is being done now without the purposes of a waiver. So it seems like if a plan was bidding at or below benchmark to try to target this population, they would try to get contracts, or they would get contracts with the states for the long-term services and supports component coming in from Medicaid. But I think it's probably less complicated than what's going on inside these waivers now, because there's the two funding streams kind of getting all merged up, money coming off of the top, one for savings, one for quality. In Massachusetts, it's 5% off the top, I think, from the combined rate. It's all the back room of those demos is very, very busy. And I think that this would simplify it and allow people to do what they really want to get to. It doesn't move the ball way down the field, but it moves it down a little bit.
All right, I think we have two more questions, and we'll come here, and then we'll end there.
Paul Sturgill from Hurley, Wisconsin, Ironwood, Michigan. A comment, and a sort of a rhetorical question. The first comment is in regard to the dual eligibles. I mentioned earlier that I focused my practice in elder law, and the heart of my work is helping families, people save their money when they end up in nursing homes and have catastrophic medical expenses. From a consumer standpoint, if we were to federalize the dual eligibles, I think it would go a long way towards giving people in that situation, my clients, certainty. For instance, I live right in a border area, and I'm licensed to practice law in both Wisconsin and Michigan. Well, if someone ends up in a nursing home in Wisconsin, the state puts a lien on their home if they're single. In Michigan, there are no liens. So we have 51 different, not including Samoa and Guam, different Medicaid programs in the United States. Federalizing the dual eligibles would put the debate on who pays for mom and dad where it should be at the national level. That's in regard to the last statement. The second thing is, in regard to the difficulty with trying to save money in our healthcare system. It seems that every time the government tries to save some money, the providers figure out a way where they can shift their costs and their profitability. For instance, we know that in part because of articles by Dr. Atul Gawande and others, that there's a concern about readmissions to hospitals. And I believe under the Affordable Care Act, and perhaps even earlier, hospitals may be penalized if they have lots of readmissions. Well, what I'm seeing in my area is that the number of patients who are admitted to a hospital for observation status has skyrocketed, because I'm told that observation status is not considered a readmission under these Medicare guidelines. And then thirdly, and this is the rhetorical question, in terms of Medicare reform proposals, what about considering seriously beginning to incrementally lower the eligibility age for Medicare? As we know, Medicare is a huge risk pool, and that the healthy pay for the sicker. And that we all know, I'm generalizing, as we get older, we are more likely to use medical services. So you would bring in healthier people, which would shore up the program, and I think that it could have a beneficial effect on the economy, because I see lots of clients who would love to retire but don't dare do so because they'll lose their health insurance from their employers. So these individuals would begin retiring, and their jobs could be filled by people who don't have jobs.
Maybe I'll comment on lowering the age of eligibility, since we did some work on that issue, sort of the opposite of that issue at Kaiser, because we looked at raising the age of eligibility. And there is, one of the interesting things about raising the age of eligibility is that it reduces federal costs, because it takes people off of Medicare, but it raises total costs, total healthcare costs. It raises premiums for people in Medicare because the risk pool is sicker. It raises premiums for people in the exchange because their risk pool becomes sicker. If you lower the age of eligibility, then sort of the inverse would happen, right? Because what you might end up doing is lowering total healthcare costs, but you're raising federal costs because you're shifting people from wherever they are onto Medicare. So it may have all the sort of appeal to those who are looking to lower total healthcare costs, and that's really an issue we haven't talked enough about in here, because if the goal is to lower total healthcare costs, that may be something that well should be considered. But so much of the focus, is kind of where we started, is on how will CBO score it? Right. Whether, who cares about anything else? How does CBO score it? And they'd look at that and say, oh, you got more people coming on Medicare? We're going to say that spends money. You want to take?
So, Tricia.
Popular, because Medicare is very popular with the general public, perhaps not with our elected officials.
Okay, thank you. Okay, this is my first boss in Washington, D.C. who's waited very patiently.
I'll take advantage of that.
We were both 5 years old.
Exactly.
Thank you, and an excellent panel. And I'm just going to share a question that was running through my mind as we heard, I think, some very positive suggestions for change. And that is why change is so difficult. And what I heard, I think I'll try to summarize in four things. Number one, CBO. There are a lot of great ideas for changing health policy that are untested and unscorable, but still worthwhile doing. And it seems like that's become almost impossible to get on the table unless we get some way to get CBO to give it some a score. And we need to think about ways to overcome that, or we're going to be stuck doing short-term things instead of what we need to do, long-term things. Second thing we need to think about is the idea of more choices in the program, which is inevitable, but that does raise the issue of risk selection among those choices. And do we really think we have a way to compensate for that adequately today? Because if not, then then that raises some unappetizing consequences if all the healthy people go one way and the people who need services go the other. A third area that I think is a real challenge for us is A, B, C, D. For example, we could do a lot better job with many chronic diseases. If people took more medications, they would have less hospitalization. but yet there's no way to, under the traditional part of the program, to transfer those savings appropriately to get the incentives right. And as long as we have a fragmented structure to the program, this is going to be a barrier to some of the things that we need to talk about. And I think that's going to be something that advocates for the traditional program really need to take seriously. And finally, we talked a little bit about changes that move policy decision-making away from the Congress. So IPAB, for example, or the example of the Secretary being able to make these choices. And I think some people and some of traditional allies are very concerned about that. But to me, that's a way of moving it away from campaign contributions and the toxic role that campaign money is playing in health policy. And by moving it away from the Congress, we don't have purity, but at least we're going to get, I think, a more likely decision based on merits. And the question then is, what role for cost? And I think, you know, it's silly for us to pretend that cost isn't going to be part of that decision making. Maybe we should talk about value so that quality and cost can be looked at together and legitimized. But I think to pretend that cost is not a factor is a way of just being blind to obvious basis for decisions, and we should be prepared to step up and acknowledge that. So that's my reaction to some of what I heard today. Thank you.
Thank you.
Can I comment?
We have one comment, and then I know where everybody wants to go after this session. So one comment, one question.
So, John, you know, I take your point around the risk adjustment, and I think it's important that it be a robust risk adjustment. I think you also probably need risk corridors in there and reinsurance. Again, following the Part D model in particular. And you need to make sure that the risk adjustment is moving between fee-for-service and the plans, you know, in a really robust way to make sure that the ship is not all tilted on one side. And then I just also, again, I have to have faith. We put risk adjustment as sort of this key stabilizing mechanism in the new reformed individual and small group markets. And that risk adjustment is going to be operating between plans inside and outside the exchange, which is a big job. So I got to trust it'll work. And then the one, just on IPAB, the only other thing I wanted to say is my comment about IPAB was that whatever decisions they are going to make, it's not going to change provider behavior or anybody's behavior sort of out in the field. You know, they're going to continue to try to maximize income, having no idea what's going to happen up here. You know what I mean? Like, if I'm spending wildly, maybe IPAB is going to take on Kavita's profession, you know? Like, it's kind of random in a way. It's not going to have a big significant impact.
Okay, I don't mean to cut you off, but I'm getting a lot of signs from authority figures here that I got to move things along. So can we have one really quick question, and we'll have a really quick answer if it's not a rhetorical question?
No, it's not a rhetorical question. I'm Jenny Chin Hansen. I'm with the American
Hi, Jenny.
Geriatrics Society. And it has to do with risk adjustment, and I'm sorry I had to miss the half of the session. But taking that point, have there been any proposals taking the model of risk adjustment to the individual level? In other words, they have done this in long-term services and supports where it's called money follows the person.
Right.
If that risk adjuster, you know, and risk adjuster is very hard. I was with OnLock, the original PACE program, for 25 years, so I'm familiar with full capitation. But at some point, having the money follow the individual rather than the provider or the institution, they've been doing that in the other side, on the Medicaid side. Any discussion really about that? Because what happens is the competition is for the person in terms of serving them well, rather than the fact that the overheads of, you know, have to be calculated differently. So that's the question.
That is definitely part, that is part of the discussion of many of these proposals, but it's challenging in how to do it, but it is there, yeah.
Okay, I'm getting serious nods. So I'm going to wrap this up. We did not resolve risk adjustment totally, and a number of other issues remain outstanding. But what I'd like to do is have you join me in thanking our panelists who are really great. I want to encourage you to go to the Holman Lounge now for a reception and the presentation of the Senator John Hines Dissertation Award. Dinner will follow at 6:15 with a keynote discussion by journalists E.J. Dion and pollsters Anna Greenberg and David Winston. So it sounds like a really fun evening, and thank you for coming.